Dear Chairman, great thanks for invitation to EBC 2021 meeting. I'm Hyo-soo Kim from SNU, Seoul National University Hospital. The title of my presentation is Long DAPT Period After Two Stenting Bifurcation in COBIS III Registry. There are still remaining issues regarding bifurcation PCI. Which one is better, one versus two stenting? When two stenting is required, such as side branch is big enough to supply a large mass of myocardium, which antibody region is better? Which technique is the best? To answer this question, about 5 years ago, we reported results of GRAND-DS registry. That is 10 years of clinical excellence. We completed 3 years follow-up results for this over 13,000 patients with 18,000 lesions treated with contemporary DS from SNU Hospital and 55 centers in South Korea. Among more than 13,000 patients, about 40% of patients were bifurcation lesion. Among them, 13% were left main bifurcation patients treated with either two stent, 80%, versus one stent technique, 20%. The results is shown here. 3-year TLF rate is 20% after two stent versus 11% after one stent. Thus, two stent was worse than one stent in terms of 3-year TLF. But when we analyze two different groups with shorter DAPT less than 1 year, longer DAPT more than 1 year, the line was totally different. In shorter DAPT group, 3 years TLF rate after two stent was about 37%, while one stent still 11%. But in population with longer DAPT more than 1 year, 3 years TLF rate even after two stent technique is 15%, very close to 11% after one stent technique. Here's high TLF rate after two stent techniques, such as 40%, can be reduced more than half by prolonged DAPT. In landmark analysis at 1 year, here, divergence really happened under the coverage of monotherapy. We analyzed independent predictors of target lesion failure in GRAND-DS registry. Here, after two stent technique, short DAPT is really a strong, poor prognostic factor to determine target lesion failure. But at that registry, we cannot get answers which technique is the best one among several different two stent techniques. To get answer from this question, we analyze COBIS III registry. Which technique is the best one? How important DAPT duration is. We enrolled more than 2,600 patients having bifurcation lesion to meet such kind of criteria from this period. Among them, 70%, 454 patients received two stenting technique, mainly side branch first or main vessel first minority. The stent technique, the acute crush technique is the dominant, more than 50%. T-stent technique, about 30%. Q-load, kissing V-stent, less than 10%. We completed 4.5 years follow-up. Here is the angiographic profiles among different two-stent technique. The sequence, main vessel first and side branch first. Which factor determines the sequence? Here, side branch stenosis grade is very important factor. If it is tightly stenosed, physician prefer side branch first. If the main vessel lesion is long, physician prefers main vessel stenting first. How about for different techniques? The most important predictor factor to determine Q-load stenting is side branch size. Here's 5 years clinical outcome. Totally, 5-year stent thrombosis is just 1.3%, even after two stent techniques. It's a very wonderful result. Target lesion failure, just 11%, even after two stent technique. There's no difference between main vessel first versus side branch first or for different techniques. Here is the incidence curve of target lesion failure up to 5 years, around 10%. Systemic versus provisional to stent, no difference. Here is loci of recurrence. About half of the recurrence happens at the side branch. Remaining half was distributed in main vessel, proximal, and distal. How about the incidence curve of 5-year TLF among 4 different techniques? A little bit higher in T-stent, less than 10% in 3 different techniques, but there is no statistical significance. Here's once again loci of restenosis. About half of the recurrence happened at the side branch. Remaining half is distributed through proximal or distal main vessels. Interesting findings, Q-load or kissing waist stenting structure is similar, same between 2 vessels. Thus, recurrence is shared by 2 vessels. Here is independent predictors of TLF after 2-stent technique for bifurcation rates in total population, propensco matched population, and IPTW analysis population consistent. Left main and short DAPT is a risk factor. When we increase DAPT duration per 1 month, we can protect the TLF. We analyzed the distribution of a DAPT duration in 46 patients with recurrence and 408 patients without recurrence. We can see the left skew deviation in recurrence and right deviation in no recurrence. Point of intersection is 2.5 years. Thus, we checked 5-year TLF rate among DAPT duration less than 2.5 years and patients with a duration more than 2.5 years. Huge difference. Such a 2.5 years also emerged in a recent analysis in other Korean population. Here, this analysis includes more than 1,100 patients with left main coronal lesion. Once again, long DAPT was better, and MACE rate declined as DAPT duration increased at least up to 2.5 years. To conclude my answers to remaining issues, when 2-stent technique is required, long DAPT is required, necessary. Regarding technique, it may be chosen depending on the anatomy of bifurcation as well as your experience. Thank you very much for your attention.